So drugs are just one piece of the pie for the treatment of chronic pain, and we've been hearing that more and more as we go on today. And so this is just an example of how it's a multimodal treatment for pain, and how we don't want to have people reliant on just medications as their sole method of controlling their pain, for sure. That it's just one piece of the pie, and you want to offer trials to certain people that might benefit from the medication, but that you need to have kind of a starting point as a trial and a way to measure the success of that, and that the outcomes are in functional activity, sleep, mood, as well as some pain reduction in order to sustain that therapy, and then to look at what's the end of that therapy going to look like, and when are we going to reconsider or consider a time at which we might withdraw you from that particular medication. So when you are combining medications, you really have to think about the additive side effects, and I think if you decide at one point that the medications really are causing more problems than they are benefiting, then you need to kind of taper people off. I think one of the principles here is if you are considering a new treatment and you want to abandon the old one, that perhaps overlapping the two treatments might be a good idea. In other words, giving some opportunity for the patients themselves to not deteriorate their current pain control. When we're looking at medications and their ability to control pain, they really aren't 100% effective. When we look at the trial data, they're always looking at, does this medication reduce the pain level to about 50%? That's the maximum that you can get in chronic pain. In general, what we see in practice is you're lucky if you get a 30% pain reduction. So patients don't understand that. They think, well, when you give me a pain pill when I have acute pain, I have basically no pain. But in chronic pain, we can never accomplish that. So patients need to understand that if we can get a 30% reduction in pain, we're really doing well. And if the medication is ineffective, then you do need to taper it off. And when you taper it off slowly, particularly when we're using drugs for neuropathic pain, such as anticonvulsants or the TCAs or other antidepressants such as SNRIs. We all have seen examples of the abuse potential with opioids, and we're all afraid of that. There are some drug interactions I want to point out. Costs are a factor. When we look at the coverage in BC for pregabalin or for duloxetine as examples, Pharmacotherapy doesn't cover those first line, so that's another added expense to people that have already lost their jobs, lost their homes, losing their families. They have no financial support to be able to afford these kinds of medications. And we've all talked about how chronic pain is not just a pain issue, it's a mood issue, and anxiety and depression are foremost to be dealt with. And insomnia is such a problem that we really need to aim treatment in insomnia. And we don't want to use drugs that worsen those, but rather can actually resolve those, or at least help them. Patients need to understand what their medications do. We deal with patients every day in the chronic pain program where they really don't understand what their medications are supposed to do. They're taking combinations of pills that still don't feel like they're reducing their pain. They're cognitively impaired. They're still not sleeping. So patients need to know what it is that they're hoping to have accomplished by taking those medications. Chronic pain patients also go to the pharmacies and herbal stores, and they start to take all sorts of other kind of concoctions. And so we need to have a good, clear idea of what all are they taking. OTC preparations, acetaminophen, Tylenol #1, Robaxacet, etc., and all the other kinds of herbal agents that they might be taking. So in terms of how do we go about choosing analgesics, this is Pharmacology 100. I mean, we see a lot of gabapentin and pregabalin being prescribed for nociceptive chronic pain, whereas there is no neuropathic component. And all that does is kind of get people more cognitively impaired. So we need to have a good appreciation of what the drugs are intended to do. And looking at, in terms of what the efficacy of a particular agent is the number needed to treat. And basically, there has been a great review recently on meds in chronic pain where they're suggesting that in order to determine a true number needed to treat for a specific medication, you need at least 500 patients that have the similar pain condition over an extended period of time in order to get a true NNT. And I think this is quite evident from some of the information that's come out on gabapentin. The NNT for gabapentin in the past was you need to treat around 3 patients in order for one to benefit. Well, when they've kind of reanalyzed that, included more trials and more patients, that NNT has increased. So now it's closer to 6. So you need to treat 6 patients before one will benefit. So I'm going to give you some NNTs just for you to kind of mull around in your mind. But essentially, about 30% of patients will get about 30% pain relief from many of these medications that we use for chronic pain. And that we do need to treat several patients before we're going to see one that does benefit. So that means that if they aren't getting benefit, they need to come off. And the safety and experience with the agent is important as well. So what we've tried to do is to just include a handful of medications that family physicians are familiar with, that they can get comfortable with, that do have evidence of efficacy in chronic pain disorders. And so it's up to you to start getting good working knowledge and understanding whether or not your patients are benefiting from it or getting harm. I just met a patient at the pain clinic the other day who'd been on amitriptyline 50 milligrams for the last 8 years for a neuropathic pain condition, and all of his teeth were rotting. And he had no money for dental coverage. He had no idea that it was a dry mouth that was contributing to all of his dental caries. So we often kind of overlook common side effects of amitriptyline and other drugs that are causing long-term harm on these people when they're taking these medications. Just like you would with any other medications, we're looking at renal function. Gabapentin, for instance, should be dosage needs to be adjusted, etc. We are usually dealing with other comorbidities in our chronic pain patients, particularly the depression, anxiety. But as we're seeing more of our elderly people who are presenting with chronic pain, we now have cardiac disorders to try and manipulate when using medications, which makes it even more complex. And we have to be aware of kind of what dosage forms are available. We always want to use oral when we're treating chronic pain, and the less frequent they take that medication, the less connection to, oh, I have pain, therefore I need to take a pill. We want to separate that association with pill taking in general. When we look at medications as pharmacists, we always want to understand, well, what is the medication doing? We know that there are descending inhibitory pathways that are noradrenergic, mainly norepinephrine. So this is where our tricyclic antidepressants and our SNRIs work. Our anticonvulsant agents work on either calcium ion or sodium ion pathways, but if we were to think that this is really, we have found the pain pathway, we have a drug to block it or interfere with it, we're fooling ourselves, because we can only accomplish about a 30, and if we're lucky, 50% reduction. So we have learned this morning that there's so much more to chronic pain, that patients need to understand that medications aren't just the only thing that's going to reduce their pain. So when we look at the old World Health Organization pain ladder, we've learned that you start with simple analgesics, acetaminophen, NSAIDs. And if that doesn't work, you add some codeine, or heaven forbid, oxycodone on the old one. And then if that doesn't work, you move up to your opioids. Well, that's kind of the acute nociceptive pain ladder. When we're looking at chronic pain, we have to kind of reinsert things so that rather than moving to opioids, we can consider, if the acetaminophen and NSAIDs aren't working, then we can start looking at tricyclic antidepressants, for instance, or SNRIs. But basically, when we look at analgesics, in terms of Tylenol, we all know Tylenol well, but in these people, we know that they often get desperate, and I have so many of them say, you know what, I went to the pharmacy, I bought a bottle of 100 Tylenol #1 and I took 90 tablets all day because I couldn't get any help from my doctor, and so I'm just going to try and manage my pain on its own. And they don't appreciate the dangers of acetaminophen and the hepatotoxicity risk. So they also kind of self-manage their pain with other analgesics, like Robaxacet, which is methylcarbamol, a skeletal muscle relaxant, combined with acetaminophen. So these people get into trouble without realizing the dangers of acetaminophen. I also wanted just to warn people that some physicians have not had experience where they have had a warfarin acetaminophen drug interaction where you can actually get loss of the hypoprothrombanemic effect of warfarin and you can get bleeding. This is normally seen with doses over 1.5 grams per day for a week, so just be aware of that. In terms of NSAIDs, we all know about NSAIDs, and if we are choosing to use them long term, or even intermittently, that the greater the risk of the GI problems and the renal toxicities in terms of increased blood pressure and pushing people or tipping people into heart failure is something we need to be really careful about. And the whole thrombosis or MI risk is well out there, and the public knows about it, they're nervous about it, and will ask you questions about that. Be aware of allergies and other drug interactions. If you have a patient that's on ASA, remember that they need to take their NSAID apart from their aspirin so that it still will work as an antiplatelet. So when we look at the numbers needed to treat for NSAIDs, it's anywhere from 1.5 to 3 for a 50% pain relief, so that looks good. But look at the numbers needed to harm. That we treat 5 people, we can have endoscopic ulcers, and 70 for symptomatic ulcers, etc. Risk factors for NSAID-related GI ulcers is readily available for you. It's kind of motherhood statements for you, I know. But one of the decisions is, should you eradicate Helicobacter pylori prior to initiating long-term NSAIDs, and certainly that is something to be seriously considered. Other people will say, well, if I'm going to use an NSAID and I'm worried about it, I'll use the COX-2 specific agents such as celecoxib, or add a proton pump inhibitor to protect the stomach, or double dose H2 antagonists like ranitidine, etc. Those are options for you, but then patients will come back, and we had one of these in the clinic the other day saying, well, I've heard that I might actually get really bad diarrhea if I take this, that the Clostridium difficile colitis is a risk with it. So again, proton pump inhibitors, when you're using it as a drug to treat side effects of another, induces new risks that you need to consider in terms of osteoporosis. The pneumonia risk is controversial. GI and B12 deficiency are not substantiated. And this is just an example of MIs associated with NSAIDs, and that naproxen is probably the safest one to use in your high-risk patients, and diclofenac is on the bad list if you'll have a look at that. So NSAIDs have a ceiling effect. Patients don't know that. They'll have naproxen, instead of taking 1,500 milligrams a day, they'll take 3,000 or more. So one needs to be warned about that. So sciatica, now are we looking at neuropathic pain happening? So what we're looking at then are agents like tricyclic antidepressants, SNRIs, anticonvulsants, and on that list are NMDA blockers, which includes methadone, dextromethorphan, and ketamine. Well, in a doctor's office, you're not really going to, typically not going to be using those. Some of you may use methadone, but generally we're looking at 3 or 5 agents. So of the anticonvulsants, which we often call neuromodulators, we've got gabapentin or pregabalin, and the NNTs for gabapentin at a dose greater than 1,200 is about 6, and that's for moderate relief, for moderate benefit, so that would be a 30% reduction, and about 7 for a 50% reduction. Issues around the literature with this is that many of the trials weren't published. So that's probably not even a true picture. I think that many of us that work in chronic pain do see patients that can benefit from gabapentin or Lyrica, and it is, again, worth a trial as long as they're not cognitively impaired. With pregabalin of doses 300 to 600, again the NNT of 5 for diabetic neuropathy, 11 for fibromyalgia, and 3.9 for postherpetic neuralgia, and again the unpublished trial issue. The only other anticonvulsant that is useful in chronic pain is really carbamazepine. That's specifically for trigeminal neuralgia. It has not been shown to be useful for other neuropathic pain states. And topiramate is kind of becoming a favorite because people say, well, it causes the patient to lose weight, which is great because often these people start gaining weight. But it's only been proven effective to prevent migraine headaches. It is associated with some significant side effects that you need to be aware of. And in terms of anticonvulsants being effective for acute pain, there is no evidence yet. One of the messages that I want to get out to you is that gabapentin dosing should be started at 100 milligrams at bedtime and increased by 100 milligrams really slowly. Remember, you're treating chronic pain, not acute pain. You have time. This way, patients can actually have an adequate trial of the anticonvulsant. Gabapentin is tricky, that it's poorly absorbed or erratically absorbed, and so the higher the dose you get, the less is actually in their bloodstream. And it takes several weeks, at which time you would see a benefit from it. So many of the patients we see have started on gabapentin 300 milligrams 3 times a day. They can't tolerate it, they stop it, it's a failed treatment. So you can restart them at lower doses. And likewise, the similar effect with pregabalin, to start at 25 milligrams and increase slowly, 25 or 50 milligrams every few days. And cognitive impairment and memory problems is significant with anticonvulsants, and something to really be dealt with because these people already have memory problems. Anticonvulsants have also been associated with suicidal thoughts and behavior and aggressive behavior, one thing to worry about. So tricyclic antidepressants have an NNT of about 4.6, and SNRIs like duloxetine and venlafaxine have numbers needed to treat of about 8, depending on that condition that they've been on. Venlafaxine has an NNT of 3. That's probably too generous for venlafaxine, but certainly these agents are useful. And in terms of side effects, remember the cardiac effects with TCAs, the sweating and the headaches and the nausea with SNRIs are something that needs to be dealt with. Again, start at really low doses. When we use duloxetine, we actually have them use 15 milligrams, half a capsule, for several days before we bump them up to 30 milligrams to see if they can't improve. And so when we're looking at TCA monitoring, we want to see, is the sleep improved? Is there any change in pain after a few weeks? And of course, mood's going to be longer overall. SSRIs have very little benefit in chronic pain, so if you're treating anxiety or depression, obviously that's useful, but generally not for chronic pain. So if you're going to need an antidepressant, it's useful to use an SNRI to both treat the mood disorder and the pain. Flexeril and amitriptyline, if you'll see, they are chemical cousins. And so when you use Flexeril, you are using a drug with the same side effects and toxicity of amitriptyline, okay? Without the benefit. When a patient can't sleep, and using benzodiazepines is a definite no-no for obvious reasons. It can push a person into depression. It does not help their pain. It's habit forming and it's hard to get off. You all know that. The preferred medications, if they are needed to add to all of the sleep hygiene techniques, is trazodone, start at 25 or 50 milligrams at bedtime. It's also complementary to any other antidepressant that you might be using. Amitriptyline is the most sedating, as you know. Nortriptyline has less anticholinergic side effects. So if we look at the numbers needed to harm for nortriptyline, it's 20 versus numbers needed to harm 1.4 for amitriptyline. So many of your patients can't tolerate amitriptyline, so using nortriptyline is better tolerated. Mirtazapine, half of a 15 milligram tablet, often is effective in patients. Again, can reduce that anxiety as well as help them sleep. And if you are to use Zopiclone, then it would only be short-term use because of the dependency issues overall.
Yep, I think a lot of people prescribe Zopiclone and stuff because they think it's not a benzodiazepine and it won't appear at the college. But it is a benzodiazepine when it's given in big enough doses. It occupies the same receptors, it has the same issues as benzodiazepines.
I think everyone always throws on Flexeril, and patients end up on 10 milligrams 3 times a day, and they're totally sedated, and their mouth is dry, and they're still not sleeping, and their muscles are still contracting. And the evidence for muscle relaxants is that they are effective for the first 2 weeks after acute low back strain. But long-term use, they are not effective. And I showed you that diagram of cyclobenzaprine, how it merely complicates therapy. If you're wanting to use amitriptyline and nortriptyline, it's best to get them off it and to taper them off. Don't stop suddenly. People can have seizures with them. Okay? So medications are one of the many strategies that you use in chronic pain patients. They should be offered as a trial, introduced at really low doses, very slowly and gradually increased while they are learning other strategies to manage their pain. And they should understand that medications are not the sole treatment, do not have huge benefit in their pain. It cannot reduce their pain to zero. And so they need to have realistic expectations of that. And they need to also know that there will be a time when that medication will be stopped, and then it will be continually reviewed and discussed about, is it now time to start trying to taper off that particular medication, because now that you have done a lot of other things to calm down that hypersensitized nervous system, that we will now be able to safely withdraw it while you've incorporated many of your self-management techniques.
Thank you.
Any other comments?
Yeah, it's just to reinforce the fact that we all know that we have used medications with no apparent evidence and it makes people better. Right? I worked in the pain clinic in Kelowna for a year, and I saw tremendous results with subcutaneous lidocaine infusions for which there was no evidence. But the guy who ran the clinic, Steve Jeffries, half of his treatment was the way he treated the patients, his communication skills, and all the stuff that Laurel and Hardy did last time that didn't work. He doesn't do any of that stuff, and it was a huge placebo effect.
And I think in a doctor's office, then your drugs on your list include amitriptyline, nortriptyline, gabapentin, or pregabalin, and that occasionally you may combine one from each category, but do that very carefully. And don't forget NSAIDs temporarily or Tylenol temporarily as well. Thank you.